Hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds. My name is Joe Ceramelli. I oversee Grand Rounds for our department. So I want to mention a couple of points about the Grand Round series, and then I'll talk about today's presenter. I want to encourage you to write any comments or questions into the Q&A or the chat. Either one's okay. I'll keep track of those questions, and I could go through those at the end. There's a group of us that works on Grand Rounds each week, which includes Samhar Abraha on coordination and communications, Mike on technology, and Charles on local event coordination on the days that we have hybrid events. There's several sources of funding for this year's series, including the Ripley Fund, the Garvey Institute for Brain Health Solutions, and the Treatment of Mood Disorders Fund. And with that, I'll just move into talking about today's presenter, who is Dr. Lois Choi-Kane. And Dr. Choi-Kane is the director of the Gunderson Personality Disorders Institute, and has had a sustained focus on personality disorders generally, with an emphasis on borderline personality disorder. And I think a very interesting and important emphasis on reach, and that's reach of clinical services, on treatment, education, and training. Dr. Choi-Kane has, after completing psychiatry residency, completed a research fellowship and had led and participated in research on borderline personality disorder, for example, looking at neurocognition, attachment, and personality, and then developed clinical services for individuals with borderline personality disorder, including an intensive residential treatment program and expanding treatment options within McLean Hospital, such as with mentalization-based treatment and dialectical behavioral therapy for PTSD training clinics. And this interest on reach, on reaching more people with borderline personality disorder, as I mentioned, relates to clinical treatments, and then more recently related to education, such as working on large-scale projects to develop and deliver educational strategies and materials on good psychiatric management, which we'll hear about today, to a wide range of individual clinicians and to schools and institutions who can then train future trainees. So I'm very interested in today's presentation. I think we have a great opportunity to learn about clinical services and treatments for individuals with borderline personality disorder, and think about ways to train others in these treatments as well. So I'll stop there and turn it over to Dr. Choi-Kane.
Thank you so much for this invitation, Joe. It's a pleasure to see you all, TGIF, and I'm honored to be the last Grand Round speaker of the year. So don't worry, I have enough slides to last you the next 3 weeks. So without further ado, I'll get started, and I definitely want to make time for questions at the end. So please do write them in the chat to Joe, and he will moderate. As introduced, I'm really interested, now that we've found progress in understanding borderline personality disorder, which I'll refer to as BPD, as a treatable illness. We now need to destigmatize it by folding into the usual care that psychiatric settings and mental health practices provide. And we need to do that by distilling the treatments that we have to be more generalist appropriate. So just for my conflicts of interest, you need to know that I do receive royalties for the sale of GPM books, and any medications that I describe here will be off-label because there is no FDA indicated medication for personality disorders. I'm going to take you through from the beginning a historical review of what borderline personality disorder meant in its introduction into the field of psychiatry. In the beginning, this was a category of illness that really took years to establish legitimacy over. And the first mention of this disorder was actually many years ago in 1938, when a psychoanalyst named Adolf Stern said that there was a large group of patients that didn't fit in the prevailing nosology of the field, that was at the time divided between understanding patients as psychotic or neurotic. So the borderline existed between these two domains of psychopathology. One thing Stern said that I think remains true, though, is that this group of patients on the borderline was difficult to handle by any psychotherapeutic method. And we know now why that is because of the major domains of psychopathology, which include interpersonal, emotional, and behavioral self-destructive problems that make it more challenging for clinicians to treat. Simply put, in the dictionary, borderline has a definition that's relevant. That's why I'm very much against changing the name, because it's meaningful. Borderline in the dictionary means a line marking a border or a division between two distinct and often extreme conditions, psychotic and neurotic. And Alan Francis is famous for saying that in American psychiatry, we're so focused on treating the worried well for some reason, even though there's a vast shortage of psychiatric services for those patients who actually have severe mental illness and need it most. So this category of patients on the borderline actually barely belong to category. And unfortunately, even though the stigmatization of these patients has lifted some over time, even within our field, a lot of very smart people don't think this is legitimate and don't think this is a disorder that is treatable, despite the many treatments that have been proven to be effective. And more importantly, personality is just something that we should basically understand in psychiatry to understand the people we treat. Personality is something we all have as part of our basic psychology. It's a special combination of qualities in a person that makes them different from others, as shown by the way they behave, feel, and think. So this is relevant to all psychiatric professionals. And if you think about different organ systems within medicine, I would really liken personality to the skin of the psychological system. Because after all, the skin is actually the largest organ in the human body. And it actually contains our whole physical being, just like personality contains psychological functioning. It's a barrier between the outside world and what's internal to us in terms of our thoughts, feelings, and urges. And the skin or the personality is what both protects and becomes damaged by what one encounters in life. It's also what's visible to others and visible to ourselves. In other words, it's how we are known and what we see in ourselves. It's our kind of passport to the world. The largest epidemiologic study done in the United States was NASARC, and that study actually proves this point, that actually any personality disorder, just based on its diagnostic criteria, was very prevalent among the over 30,000 individuals assessed in that study. Over 20% of all participants met criteria for some personality disorder, and the most common of which was obsessive compulsive personality disorder, followed by narcissistic and borderline. But some people in the field that are familiar with the rates of prevalence across different studies thought this was a little bit too high. So there was a little bit more of a stringent criteria applied to the same data, where the qualification of significant distress and impairment was really held to higher standards. So the adjusted rates went down some, but they were still significant. About 1 in 10 people in our country will meet criteria at this more stringent standard for any personality disorder. And what's interesting is obsessive compulsive and narcissistic rates go down considerably. And that suggests to me that there's something about these personality syndromes that can be adaptive in some cases and maladaptive in others. Borderline does not deflate as much, and that is because its symptoms actually demarcate a more unstable and impaired condition. And that's why, of all the personality disorders, BPD is the most significant one to learn how to treat. So many of you will be familiar with the DSM standard criteria for this disorder, which I oftentimes really divide in 4 sectors of psychopathology, which have been replicated in factor analytic studies. There are the interpersonal features by which this disorder is best known and best differentiated from other disorders. And then there are the self-destructive, reckless, impulsive features, which bring these patients into care. The emotional instability symptoms of BPD have the highest negative predictive power, meaning that if you don't have unstable mood, you're not likely to actually have BPD if you meet some of the other criteria. And lastly, there's this kind of miscellaneous category of thought and identity that is a distorted and unstable negative sense of self, as well as a tendency under stress to become disconnected in one's thoughts, sense of identity, and body related to dissociative and paranoid phenomenon. But the story I often tell clinicians and patients goes a little bit more like this, now based on what we know works treatment-wise for this disorder. We think in many of these treatments that work, whether it's MBT, mentalization-based treatment, transference-focused psychotherapy, or good psychiatric management, we feel that the interpersonal symptoms of borderline personality disorder is its most distinguishing core feature. These symptoms of unstable relationships defined by a tendency towards idealization and devaluation, as well as attachment instabilities that get played out in frantic efforts to avoid abandonment, those features drive emotional dysregulation and vice versa. These 2 parts of the disorder are highly interconnected. And what happens with this kind of fiery, volatile core is that the interpersonal hypersensitivity and its relevant emotional dysregulation actually creates enough arousal in the system to unseat cognitive control. And that's what gives rise to these impulsive symptoms that we know well and oftentimes bring these patients into treatment because they are the most risky and dangerous. Now, the cognitive features are also related to this unseated frontal top-down regulation process in the brain. That is this ability to discern thoughts from reality and reappraise one's own emotionally driven estimation of reality is impaired. And when there are this many sectors of instability in one's psychological functioning, of course, your sense of self, your ability to be stable and coherent is impaired. And this damages your self-esteem. That makes sense. So in modern studies that use some more advanced statistical approaches, there has been this finding that BPD actually only maps onto a general factor of personality disorder symptoms, whereas the symptoms of other personality disorders are more specific to those disorders. And what that suggests is that BPD is a prototype of personality disorder, that it represents the most serious problems of self and other management, and it may be in and of itself a disorder that is a severity indicator of personality dysfunction. So Peter Fonagy, from whom I've borrowed this slide, said that BPD is probably something like a general vulnerability to the persistence of psychiatric dysfunction and low resiliency. And that's why BPD is oftentimes comorbid with a variety of disorders. Similarly, in a different data set from Carla Sharps, Aidan Wright, using the collaborative longitudinal study that was multi-site, found that the same thing, that there was this general personality disorder factor on which BPD tended to load exclusively as opposed to the other personality disorders. And Aidan Wright actually had access to longitudinal data in this sample that he used, and he found that actually this BPD factor, the general factor, has the greatest degree of change over a decade's time. That's what's amenable to treatment and maturation over one's lifetime. And actually, functional difficulties do improve on some level that seem to track with these changes in the general functioning. Because if you look at the other traits of personality, they don't seem to actually have as robust changes over time. So if you look at this blue line that I've just traced, that's actually employment. So you see that with this general improvement in personality functioning or a reduction in BPD symptoms, a person's basic ability to contribute to society and hold down a job is actually improved. Now, many of you will ask, what about the alternative model for personality disorder, which is just in section 3 right now? The APA is considering whether or not to adapt it, and there's still not enough data to do so, in my estimation. But this model is still important and helpful to think about in terms of our clinical work. Whereas the categorical model of personality disorder really divides people up into yes or no having a personality disorder, the dimensional approach enables us to consider this on a spectrum starting from non-pathological or healthier to something that's more of an illness or psychopathology. And we say that we can use this dimensional model and this G factor or general factor of personality disorder construct to think about personality disorders at large as more rooted in a problem of self-management and interpersonal relationships. Now, you at UW know very well the work of Marsha Linehan, who really focused on emotion dysregulation, but I would argue that has less to do with personality functioning and is more a transdiagnostic model of psychopathology that's very relevant across a number of illnesses, but doesn't quite capture what a personality disorder is alone. So in this alternative model, what it helps us appreciate about patients with personality disorders are there are problems on the side of managing oneself in terms of one's identity, self-direction, and self-esteem, as well as in interpersonal processes. That is the ability to empathize with others and also to get close enough and be supported by others in terms of intimacy. Now, moving on to the facts, we all know that this is a common disorder, both in the general population. It's as prevalent as other major mental illnesses that we learn loads about in our general psychiatric training. And the rate of BPD is actually comparable in both adults and adolescents. There was this idea that it was more common in females only because those individuals are more highly represented in the clinical population than in males, but in the NASARC study, they found that it was comparable between males and females alike. And actually, those groups who are more on the borderline in their identity facets tend to be meeting more of these criteria because they are marginalized, excluded, isolated, pathologized, stigmatized. That brings out some of these symptoms of not belonging. Now, the good news is these individuals show their distress and actively seek care. They're prevalent at all levels of healthcare, even in primary care settings. There is an overrepresentation of patients who meet the criteria for BPD, as well as in any psychiatric setting, whether it's ambulatory or more acute. And in fact, in inpatient hospitalizations and emergency department rosters, when patients are presenting with suicidal ideation, a good half to more of these patients will meet criteria for BPD. A study published recently by my colleague Robert Gregory has shown that among inpatients with suicidal risk, about half of them will have BPD, but 68% of those patients are misdiagnosed or are treated with a focus on another disorder that's not likely to respond to treatment without addressing the BPD. And those suicidal patients with BPD differed from those without BPD by being younger, on more psychiatric medications, even though none have been FDA indicated for the disorder. They're more depressed, they have greater suicidal ideation, and they're 3 times more likely to be readmitted to the hospital because the treatment they get does not address their central problem. Of course, these patients are well known for their suicidal ideation, and they keep expressing it because they're not getting their needs met in some way. 4 out of 5 patients with BPD will engage in some suicidal behavior in their lifetime, but luckily, the average number of attempts only amounts to 3 over a population or in a sample. And we know from the suicide research literature that 1 suicide ends in death per 23 attempts. So this means there's a large margin of intervention, that most people with BPD will not die by suicide, but we still have to do a better job of finding those that will. And that's research that's under development. Now, this is still 50 times greater or more than the general population. So these patients are at the greatest risk still for dying by suicide. And in fact, in large studies, identity problems, frantic efforts to avoid abandonment, and emptiness predict suicidality better than other symptoms of other disorders that are common. And yet they're very rarely assessed in acute evaluations. Self-injurious behavior is quite distinct, and even though it's not immediately dangerous and doesn't warrant inpatient hospitalization, it still over time escalates the risk for completed suicide by 2 to 30-fold. Now, what about this? I think we tend to be very binary in thinking like, oh, if it's not true suicidal ideation and behavior, and it's just self-harm, they don't really need that much acute treatment. But I think there are more blurry lines between these categories, and they oftentimes co-occur. Self-harm is a behavioral hallmark of BPD. And while not all people with self-harm will meet criteria for BPD, about 60% will. And it's an early indicator of something going wrong for the young person. Across several studies in several countries, the lifetime prevalence is quite high. It's about 16.9%, and the mean onset is at the threshold of adolescence at 13. There is a lot of heterogeneity, but there is a split where approximately half will be mild and require no intervention at all, whether medically or psychologically, but about 16 to 27% will be repetitive and more severe. And these will be indicators of a person that is just at higher risk psychiatrically. And this increases the risk for completed suicide because it lowers the barriers that prevent suicide. Now, machine learning approaches and statistics have enabled researchers to have predictors over time, prospectively. And this really cool study done by my colleague Stephanie at Cambridge University in the UK used a large cohort called the Millennium Cohort of 10,000 individuals that were assessed at age 5 to start in the London, UK kind of community. And then they reassessed them over time. And at 14, they found those individuals who actually engaged in self-harm. And they found 2 pathways to self-harm. The more kind of predictable pathway was called a psychopathology pathway. And this was actually only a fraction of those who self-harmed. These kids were more likely to be bullied, have poor emotional regulation, have difficulties in school, cognitive limitations, and parental challenges. But interestingly, a larger group was harder to predict because they represented a risky adolescent sample. They were more risk-taking and less secure in their relationships, but otherwise were difficult to identify early on. Both groups were distinct from the group that did not self-harm because they both had problems of sleep and lower self-esteem. And these are markers we can look out for early on. Now, this happens in the adolescent period, which is not just a stressful social period, but a period in which a lot of active work is being done on identity formation. Kids are departing from the nest of dependency relationships, navigating amongst very socially inept peers, and also facing more demands from adults with less support. They say that BPD is just normal teenage behavior. And on some level, this is true because from the age of 8 to 16, there is a normative increase in BPD symptoms across all individuals in that age group. But what happens to most of them is that that peaks, and as they develop more stable identity functioning and self-functioning, this decreases and goes down over time. Now, there is a discernible set of peers who start higher and then stay higher. They do not have this normative decrease in adaptation, and those are the people who go on to have BPD more problematically. And these kids can be identified earlier. Not only do they have a higher burden of symptoms that interrupts their developmental trajectory, they also become more distant from their peers, and they become isolated on the borderline of the social group that belongs. And it's this condition that contributes to the symptoms that we see. So what happens here is actually a more complex story than the ones that the psychoanalysts told us in the day, that parenting was responsible for some of these things, or attachment was the basis of borderline personality disorder. We actually know from prospective research, this is not actually the case. Kids are born with certain endowments temperamentally and biologically that make them express BPD symptoms earlier on in life, such as impulsivity and negative affectivity. Our colleague Stephanie Steff found in a large study that was very representative in Pittsburgh, Pennsylvania, of girls in that community, that these symptoms, when they were present early on, predicted harsh punishment and lower warmth in parents at all age points. And it's only at the age of 15 that kind of parenting predicted BPD symptoms. So there is a more complex relationship between temperamental endowments, the kinds of parenting those kids get who are already more at risk and get less support and more adversity from their parents. And that feeds back to risk of developing BPD. This is not just in the US. In the UK, the same findings were true in a different sample where kids with dysregulated behaviors were more likely to be bullied and have maladaptive parenting. And then that experience was predictive of having greater BPD symptoms at the age of 11. Now, most adult studies look at this in a different phase. Once BPD is an endpoint of the developmental process of adolescence. And once someone has declared themselves to have BPD, over 10 years' time, the good news is that 4/5 of those patients who met criteria for BPD at baseline will remit from meeting diagnostic criteria, and their average number of symptoms will go from 6.5 to 1.7, meaning there is still a core temperamental aspect of BPD that remains even after symptomatic remission, and that symptom tends to be being depressed and anxious when alone, isolated, and not belonging. Now, the interesting thing is, despite this vast symptomatic improvement, functioning seems to not increase over time. And I think it has to do with this lost developmental process and opportunity in the adolescent and young adult period that brings them off the path that most people are on to building a life and the skills they need to build that life. And that's why earlier intervention is critical, because BPD predicts academic functioning. BPD is associated with worse academic and behavioral functioning in schools. And these patients have a lower likelihood of graduating either from high school or from college than patients with other disorders such as MDD. The good news is if these patients do remit from BPD, they're more likely to have good work and school performance that then feeds into their identity and relational functioning versus patients who don't remit. And in particular, in this age range, self-harm, impulsivity, and affective instability uniquely account for variance in academic achievement and social maladjustment. And this story, of course, is the same in occupational functioning, that BPD traits are obviously related to problems at work in all these different ways. And compared to individuals with other psychiatric diagnoses, those with BPD who tend to actually have good intelligence and kind of palpable skills, they still have a 32% lower odds of working 9 years after their diagnosis than other psychiatric patients. And again, remission predicts good work performance versus non-remission. We now think that actually poor occupational functioning is predominantly to blame for failure to recover, because people will actually have lower symptoms and just hide out from life, and then they won't actually function. So work may buffer against the worst health effects of BPD. Work itself provides a social network, and there's many means to building a social network, but BPD alone makes it more challenging to take advantage of a social network and use it to manage stress. All of these things occur for those with BPD at a greater frequency than those without BPD. And in general, social exclusion impairs self-regulation for all humans. And interestingly, in both animal and human studies, the size of one's social network linearly relates to the size of the social brain, the orbital prefrontal cortex. And that's mediated by mentalizing capacities, that is, social cognitive skills. And conversely, self-regulation facilitates the ability to be socially included. These are bidirectional effects, and that's what I think we need to foster in individuals. After all, Freud, a very long time ago, said the price of civilization is instinctual renunciation or self-regulation. Being a part of society requires self-regulation and vice versa. Now, the costs of this disorder are fairly significant. It's greater than that of depression and anxiety, similar to that of schizophrenia, even though it's quite treatable. And in the US, with our broken healthcare system, this is costly at all levels. And early BPD symptoms increase the risk of being unemployed and on disability. So it levies a huge cost to the government. And this is another argument for earlier intervention. So what do you do in treatment? Well, the short story of this is that there are no medications we can use. The bad news about that is that it makes it harder to treat with less clinical resources. So few RCTs have been studied. People are afraid to do drug trials with BPD because of the level of suicidality. It's that extreme. And no medication has ever been uniformly or dramatically helpful. And if you understand the nature of the disorder, of course not. None is licensed by the FDA, but still 90% of these patients are on at least one medication, 20% on unguided polypharmacy. So deprescribing may be the psychopharmacologic task of interest for these patients, because more medications often reflects low responsiveness to treatment and a desperation or futility to do something to help. Now, you probably have heard of these treatments that have been found effective, but they can't be found anywhere. Even for a specialist setting like McLean, they're just unaffordable. I don't know if I could afford these treatments if I needed them, because the supply is super inadequate to meet the demands. And it's just a law of microeconomics that the supply and demand intersection drives the price. So I don't have to tell you about what these things are. DBT, you know well, because it was born where you are. Mentalization-based treatment was developed in the Anna Freud Center and University College London in the second poorest district of London. So it is designed for the National Health Service and very well proliferated across Europe where there are national health services. Transference-focused psychotherapy is born out of the work of Otto Kernberg and is more oftentimes practiced by psychodynamic psychotherapists. It's also oftentimes done in settings where psychotherapy has good healthcare coverage, like in Germany, or where there is private practice. And general psychiatric management, or good enough psychiatric management, is still more intensive than the average treatment in psychiatry once weekly in the trial that studied it. But we are really saying you can be pragmatic with this. But basically, the gist of it is to facilitate the natural course of improvement and foster a corrective experience through getting employment and getting a life. The good news is that across very good, high-quality meta-analytic studies, there is no difference between these treatments, even though they differ considerably in contents, orientation, and intensity. And in fact, the duration and intensity are not related to treatment outcome. It's also surprising to find out that the specialist treatments actually did not do better in retaining patients, as they often claim to do in discrete trials. So now that we know this, we have to think about, okay, what can we do in terms of minimal optimal dosing to improve population mental health? Because these intensive treatments only have small to moderate effect sizes, and if only a little sliver of our community can get them, that does not make good public health. So this cartoon depicts what I'm talking about. It says, "I'm sending you to a specialist. Don't tell him you know me." Now, this rings too true for me. I know a lot of people in psychiatry have had a very blessed career, meaning a lot of good professionals across the nation. And literally, when I call them, they might be very friendly unless I say I have a patient to refer. And they tend to not call me back as rapidly. And I can relate to this because it is impossible to find treatment, even for me to find a treater with a patient who can self-pay. Everyone's full. Finding treatment for insurance-based patients is even harder. That the treatment of borderline personality disorder depends on specialists, and yet the supply of that is inadequate to meet public health needs. This was in psychiatric services, and it showed that even in the best resourced countries in Europe and in Australia, there are only enough providers for those who have BPD and seek treatment if all generalists saw these patients. And maybe in these countries, they might be able to, but they're not going to be able to do MBT, DBT, or TFP. And in other nations that aren't even that disadvantaged, this would lead to rates or caseloads that are just frankly untenable. And if we only relied on certified specialists, this would be just off the charts impossible, even in the Netherlands that has an established center of excellence for the treatment of personality disorders. So this begs this question. I think I've set you up for the obvious answer to this, and this leads to what I have to say about general or good enough psychiatric management, which preserves the medical model of psychiatry in treating BPD. It's meant to be for the generalist. It's not the best treatment out there, but it's good enough and scalable. And it holds on to something that has to do with general psychiatric practice, not just psychotherapy. Because medicalizing the treatment for BPD provides a stabilization to the interpersonal problems of BPD. It establishes roles that are systematic across healthcare, goals that is in reducing symptoms and improving functioning, and more importantly, establishes a very transparent universal system of communication across disciplines and across domains of treatment. There are many levels of care within our field where clinicians treat patients' mental health concerns that will never use any of the specialist treatments. And in fact, at low doses, it's questionable whether or not it's helpful or harmful to use those treatments because they're so complicated. So just to review, you know that these treatments are limited in access, and even across all treatments, the dropout rate of BPD patients in any treatment, given the challenges that they face to just live life, is high. And the non-response rate is striking, even though on average in a sample, there are statistically significant improvements over placebo or comparisons, there's still a high rate of non-response, even in a successful trial. So we need to boil this down to what really works in these treatments, because I doubt it's the 300 skills in MBT or the different mentalizing modes of MBT or in the particular interventions in TFP, because they all have certain things in common. And what those things are a well-specified formulation of BPD, a consistent set of techniques around that formulation, and a durable relationship that can be established with a lot less. And that's been kind of the ingredients of good enough psychiatric management. Now, thanks to Shelley McMain, we know that these treatments are comparable in their effects. This was a stunning outcome of very high quality DBT run by a very well-respected DBT therapist and researcher in Toronto, who was the first to carry out a trial of this scale outside Linehan's lab. And she found no statistically significant differences between DBT and GPM, even though GPM was only one session a week and DBT was 2-hour skills group, out of session paging, and individual therapy with consultation team. And in 2-year follow-up, still no statistically significant differences between these two treatments. And if you look at this, DBT is blue. When the treatment ends, there's an elbow where the effects level off, whereas the GPM lines are a little straighter, which suggests this treatment still continues to work based on its principles, not just the structure of the actual activities. And what we do is based on what most clinicians do across healthcare, providing a diagnosis with psychoeducation so that patients know their symptoms, teaching patients about the prevalence, that they're not alone in this, and the course that they will get better, but they will have to work on their functioning in order to recover. And that there is a biological basis, that it's not their fault, nor is it their parents, but they do have a responsibility to manage their vulnerabilities. Disclosing the diagnosis actually brings relief. And there is this myth that you're going to harm the patient by disclosing the diagnosis, but really, are we that self-centered by telling someone the label of the thing they have is worse than them actually going on to have that condition and not know it? I think any of us would be upset with the idea that we could have been told 10 years ago that we have something that we can work on that's treatable that other people have, and then miss out on the formative years of our life. Those with this disorder say that the diagnosis and hearing about it was a turning point of having a clear conceptualization of their experiences and their emotions, and that this helped them to move on to recovery. The worst thing was when they received the diagnosis and weren't given any information about it that was constructive. So what we think you can do is something like low-cost 6-session GPM psychoeducational group. This was done in Italy by Maria Rodolfi and her group. And they just provided 6 groups where they covered topics that are in GPM. And this group psychoeducation yielded greater improvements in 3 of the 4 sectors of BPD at the end of treatment compared to waitlist. And those improvements were sustained for 2 months. And this can be really useful for an actual waitlist, because half this treatment group actually reduced their symptoms by 50% or more. And only like 1 patient on the wait list actually achieved that result. So the formulation in GPM goes a little like this. Because people with BPD are so insecure and self-doubting, they can't rely on themselves. They have an unstable sense of self. They rely heavily on others who they idealize. And when they're connected to others, they're well constituted as they can be. But because they're so dependent, they're going to be vigilant to interpersonal threats to that relationship. And whether real or perceived, those interpersonal stressors, which are inevitable, will lead to a threatened state. That is fight or flight. And I think we recognize those modes in the symptoms of BPD. And then those fight or flight responses are maladaptive in BP. Lashing out or lashing in actually scares people or frustrates them so that others generally withdraw. And that's the very thing this patient is trying to avoid, is abandonment. But it happens because of their maladaptation and dysregulation. And it's in this actual state of aloneness that they become unanchored from reality, the reality of the consequences of their reckless behavior and paranoia, as well as dissociation. And it's in this uncontained, unanchored state that people understandably feel more despairing and actually become suicidal. And this is where the point of risk is. They need a holding environment, which we actually intuitively provide by providing hospitalization and even in some cases, jail or police. And this reconstitutes a social connection, whether comfortable or uncomfortable, and restores them either to a connected state or a more threatened state, either of which are more workable than aloneness or despair. So what we say in GPM is lean in when the person is threatened and try to work things out with them to keep them between the connected and threatened state. That's what most of us do all the time. And this is about teaching clinicians to be unafraid to get it into the dirty work of dealing with people's anger. If we can't do that as psychiatrists, who will? And this isn't just about BPD. This is about humans in society, because this happened on a much larger scale. Here on January 6th, people who felt on the margins protested in a way that could have been destructive to them and to others. And we need to lean in and figure out how to do this differently to come to better solutions that work better for society and for the individuals in it. Because a civilization that leaves so large a number of its participants so unsatisfied drives them into revolt, and that will undermine the stability of that civilization. So what I'm saying is you need to lean in here, because even when people are threatened, they're trying to do something within the relationship. They're sending signals. They need you and want you. But we oftentimes wait until this happens, and we have to take unilateral action that only reinforces their passivity and their dependency on the system. So GPM invites an eclectic approach using features of these other treatments, but in a simplified way. I'm going to not go through this because of interest of time, but GPM really interdigitates with all these different methods and uses this core formulation to do the central tasks of psychiatric treatment, such as managing safety. We understand suicidality and self-endangering behavior is a reaction to interpersonal stress for those with BPD. And then we will say to them, I can help you manage these behaviors that are suicidal, but to diminish their cause, we need to help you find better social supports and better means of sustaining those social relationships. Then we use general psychiatric management principles to estimate risk for suicide, including an understanding of risk factors that increase risk, such as negative interpersonal events, substance use problems, increased depression, and step downs from intensive care, and events that decrease risk, like interpersonal support, safety planning, crisis skills, low-dose antipsychotics, and hospitalization. And we use those as part of the safety management by estimating the dangerousness of the situation. So part of the safety plan is really emphasizing the need to find people to help you feel less alone and not always lead with the calling card of being suicidal. We also sprinkle in group therapies that teach patients that others have similar problems and different ways of coping with them. These groups highlight how these patients impede making close partnerships that they want, and that these groups can help you change those patterns. Moreover, group therapies can help patients learn to listen when people express feelings they usually avoid, and they can understand better why people have those feelings. There is a lot to gain from these groups, and I won't go through this in detail, but groups in general provide a forum for socialization that might be more important than individual therapy alone. And studies have shown that groups may be the central action point of the effectiveness of the treatment. The dismantling study that Marsha Linehan did and published in 2015 showed the DBT skills group plus good case management was statistically not differentiated from the full package of DBT. Now, the last thing about GPM is it addresses comorbidity. In fact, in the McMain trial, those patients who had greater psychiatric comorbidity and higher impulsivity dropped out less frequently from GPM as opposed to DBT. And in some kind of matching analyses, there were certain patients who had this profile of greater comorbidity that did better if they were matched with GPM versus DBT. So what GPM does is use longitudinal literature to say that actually in most cases you need to prioritize BPD treatment because the other disorder is less likely to remit or likelier to recur unless BPD is in remission. And that includes depression, anxiety problems, bipolar, that's euthymic, as well as bulimia. Now, you want to prioritize the other comorbidity or co-occurring disorder when it precludes active involvement or learning, stable cognition, such as mania, ADHD, severe substance dependence, and anorexia. And then there are other disorders that require treatments that are stressful, like exposure therapies, panic disorder, PTSD, and OCD, where you do want to stabilize the BPD so that you can treat these disorders. Now, for example, we need to move towards treating some of them, not sequentially, but simultaneously, such as alcohol use disorder, which is almost normal in BPD. About half of all patients with BPD will meet criteria for alcohol use disorder, either concurrently or over their lifetime. And there are transactions between BPD and alcohol use that are distinct, and they actually create a vicious cycle where the traits will predict alcohol use problems and greater rates of onset and relapses. And then the alcohol use exacerbates BPD to create circular effects. And this is a suicide risk factor. So if we treat the alcohol use disorder aggressively using the standard of care, this is an intervention to diminish risk for suicide. And why we don't do that, I don't know. Despite the common kind of prevalence of this co-occurring set of disorder, there are few treatments that have been trialed on it. The one that has been found effective is dynamic deconstructive psychotherapy, and Robert Gregory has helped us write GPM for AUD and BPD, which is in the hands of Abbey Press right now for publication next year. We did this because a 10-session variant of GPM was found to be as effective in a BPD and SUD group as a BPD group, and in fact was more effective in reducing BPD symptoms and increasing therapeutic alliance for the SUD group than the BPD alone group. This still needs to be studied. So to wrap up, the major mechanisms of GPM are simple that we would teach any psychiatric patient. Think first, develop corrective relational experiences, understand people are flawed and limited, not bad or evil in most cases, and get a life, because life itself provides the nidus of creating self-esteem more directly through work and school-related activities. So you teach people to understand social transactions, to be more social and cooperative, and shift from interpersonal hypersensitivity to self-reliance. And that will help people in their quest for work and love. Because after all, as Freud said, these are the cornerstones of humanness and the building blocks of personality functioning. So I shall end. GPM training is 8 hours online. supported by philanthropy, and it is translated into these languages. So thank you very much.
Well, thank you, Dr. Troykin. Walking through the clinical literature, talking about clear examples, helping us understand a common clinical problem many of us encounter routinely, and understanding ways we might try a different treatment model in the settings that we work in. I would like to encourage participants to write in with any questions or comments. We do have a few minutes for questions. And I think as people are doing that, maybe I'll just pose something. I was curious about the wait list, the GPM group session for those on a waiting list, and it might be a waiting list for many things.
Yeah.
Is that, do you have experience with that? Has that been something that you've put into a clinical service?
Yeah, you know what's interesting is across studies, the first 12 weeks of treatment is where most of the change occurs, whether it's Lamictal or placebo or residential or 10-session GPM. If you look across the literature, actually patients who are at high symptom burden, they should not be on wait lists. They need treatment now, but there's not enough of it. So they're on a wait list, and whatever you give them, actually the only way from there is either unfortunately death or recovery. And so if you provide just enough support for them to stably just kind of be contained and helped enough to come down, whether it's even placebo with good psychiatric management or this group psychoeducation, I think we can do less to do more. And I think it's probably the psychoeducation of all treatments that is a common factor. That's the engine of a lot of the change. Just telling patients what they have and how to manage it is a starting point that everybody has a right to.
Yeah, it's very interesting. I mean, I think you had mentioned sort of leaning in when symptom severity is higher, provide the treatment. I mean, it makes a lot of sense. Yeah.
That's what we do for a heart attack. I mean, we don't put people with a heart attack on a wait list. That's ridiculous.
It kind of goes along with the concurrent treatment of problems as well. You also wouldn't wait to initiate treatment for hypertension in that setting as well. Yeah.
Exactly.
A question about hospital-based care. This came in. Clearly, perhaps several different reasons, many reasons why an individual with borderline personality disorder might be admitted to a hospital. What's a consistent framework in this setting?
Same thing. There's a chapter in this book. I'm not just plugging my own book, but it was the last chapter John Gunderson wrote. And it's on inpatient hospitalization, where he talks about 4 steps of inpatient hospitalization using GPM. And it's adapting to the unit, doing a chain analysis of what brought them there, making an action plan for addressing that once they get out, and then discharge planning, and keeping it active and really evaluating the inpatient treatment based on the effectiveness of reducing symptoms and being reduced over time. So the patient should have fewer hospitalizations over time. If they actually escalate hospitalizations, then you have to ask the patient, is this actually effective coming back and forth to the hospital, and figuring out why it isn't? Because hospitalization occurs because it works on some level, and some people will use it appropriately. So I wouldn't kind of shy away from it, but try to use GPM principles to make it effective and focus on life outside of treatment than the drama in the treatment.
Thank you for mentioning that and responding to that question. There are more questions I think that people may have or want to write in. I'm wondering, I mean, talking about training, have you taught psychiatry residents to do this, supervised in some way? Is it part of just the general caseload, or is it broken out into something different or separate? How does that work in practice?
We have this online training, and a lot of faculty have been trained to train residents in this modality. And there's actually a chapter in the same book on supervising trainees using GPM. But what I'd say is we also are currently in a study, the paper got published yesterday, on an online psychoeducation and assessment platform where I made 10 psychoeducational videos to cut out the training part of the psychoeducation and just write video prescriptions that primary care providers, generalists, nurses can all write, emergency room physicians. So that's coming down the pipeline, because even the transition of very simple training to incorporation into usual practice is very difficult in this day and age of healthcare, where there's high demands and high burnout and low levels of time to spend with each patient.
And those will be on the GPM website? Someone just asked where to find those.
I will send you the paper.
Okay.
And you can make it available. But if
That's-
anyone's on LinkedIn, I post everything on LinkedIn, and I just posted on that paper today if you look me up.
Okay. Well, here we are just after 1 o'clock Pacific, and time to end. Clearly more questions. People are writing questions still that we unfortunately just don't have time to ask.
I'll come back anytime. My best
Okay.
friend from college lives in Seattle, so I'd be more than happy to come back.
Oh,
So,
great. Well, thank you. Thank you, Dr. Troikin. I appreciate it. And thank you for joining us today for Grand Rounds.
thank you for the invitation. Happy end of 2023, everyone.
Same to you. Take care.